Welcome to the webinar today. I'm Dr. McCannel. I'm the director of the Ophthalmic Oncology Center at UCLA, and I'm a member of the Department of Ophthalmology at the Stein Eye and Doheny Eye Institutes at UCLA, and it's a privilege to be here to share with you a little bit about our program today. So today I'm going to be telling you about uveal melanoma at UCLA, our evolution to a modern approach to ocular oncology. And feel free to Twitter in your questions if you have any. I'm happy to address them at the end. I have no conflicts of interest. And before I begin, I just want to acknowledge the people that make our team and what we do possible. My chairman, Dr. Bart Mondino, Dr. Bradley Stratsma, who was the original founder of the Institute and a great mentor. The others on our Ophthalmic Oncology team, Dr. Colin McCannel, Dr. Glasgow, Dr. Chun, Robert Almanzor, and my colleagues in radiation oncology, Dr. Kamrava, Dr. Dumanis, Dr. Lamb, and finally our colleagues at the Johnson Comprehensive Cancer Center, Department of Hematology Oncology, Dr. Rebus, Dr. Himalowski, and Dr. Goldman. So today I'm going to share with you a little bit of background about ocular melanoma. What is this cancer? How do we know people have it? And I'm going to go through some of the goals of our center at UCLA, and then highlight a few of the specialties of our program at UCLA, including a discussion about fine needle aspiration biopsy, preventing radiation retinopathy, some of our strategies, as well as treating other conditions such as retinal detachment. So what is ocular or uveal melanoma? This is the most common primary intraocular tumor of adults. It's extremely rare. There are only about 5 to 6 million cases per year, so around 2,000, 2,100 cases per year in North America. And we don't really know why people get this. We know that people tend to have less pigmentation, so they may have lighter skin, and people may have blue or green eyes, more so than people who have dark pigmentation of the eyes. And here's a typical picture of what a melanoma looks like in the eye. Melanoma of the eye is not known to be hereditary, so that means you cannot pass it along to future generations. However, it may be associated with other types of cancers in a patient's family. It originates from the pigmented cells in the uvea, and this word uvea really means the collection of iris, choroid, and ciliary body, and we'll go through some of that. So when we say ocular melanoma, it's the same thing as saying choroidal melanoma or uveal melanoma. So we're just going to go back to some basics. Here's a normal human eye. Everything in the front here is called the anterior segment. Everything in the back is what we call the posterior segment. So the front of the eye has the cornea, which is the clear cover. The lens here is what forms cataract when people get older. The iris is sitting just in front of the lens. And everything in the back of the eye, it's filled with a substance called vitreous humor. And the retina is indicated by this red line. And underneath the retina is the choroid. And the choroid is a very vascular layer where there's pigmented tissues where melanoma can form. And here is sort of where melanoma, how we see it in relation to the eye. So, when people think of eye melanoma, it's usually sort of growing from the wall of the eye or the tissues on the wall of the eye. Here's just an example of an eye that was removed because it had a melanoma. And you can see here the melanoma is sort of this mushroom-shaped mass in the eye. And you can see that this fine line there is the retina, and there's usually retinal detachment associated with choroidal melanoma. So how do we find or diagnose melanoma? It's often detected on a routine eye exam. A person will go for a glasses checkup, and an examination may be performed inside, or a person might have photos done on the inside of the eye, and then a black mass is found. Another way a patient might notice a change in their vision, they might have some blurry vision or have a new blind spot or see flashes, and then they'll get checked and a melanoma can be diagnosed. And then finally, some people know that they have a pigmented freckle or mole in their eye, and melanomas, like freckles on the skin, can also transform into a malignancy. Here are just some examples of what melanomas look like. And these three here are from inside the eye, and down to the right here is an iris melanoma. And you can see here that melanomas look many, so they're not always very easy to diagnose. So it's important to be evaluated thoroughly if one is suspecting a possible melanoma. So how does melanoma affect patients? Well, in two big ways. One is that there can be vision loss, and people can lose their vision because the tumor itself might disrupt the eye and cause retinal detachment. And then when a melanoma is treated, there are side effects that can occur which might affect the vision after the melanoma is killed. And the second bigger reason that melanoma can affect patients is metastatic death, and that's when the melanoma spreads outside of the eye. And in ocular melanoma, for reasons we don't quite understand, if the cancer does spread, it tends to spread to the liver. And I should point out that it's actually very rare to have metastatic spread at the time the eye melanoma is diagnosed. So let's talk a bit more about ocular melanoma metastasis, because this is the part of the cancer that is most critical. In about 50% of patients, and that's taking everybody, all shapes and sizes of melanoma, eventually metastasis can occur. And as I mentioned before, most of the time it's in the liver, which is over 90%. And then after liver, the lungs, bone, and skin can also be sites of cancer spread. Unfortunately, at this time, we have no prospective clinically trial proven treatments to help melanoma. And some of the treatments that may be offered if metastasis is found is surgical resection, chemotherapy, including chemoembolization, which means focusing the chemotherapy at the liver. And there are many clinical trials ongoing that a patient with ocular melanoma that has spread may enter. And the world of treatments for metastatic cancer, as you may know, continues to evolve very rapidly. So we're hopeful that at some point soon there will be something that will be helpful for patients who have metastatic spread of the ocular melanoma. Now, what is associated with the risk of metastasis? Because we know that not every patient with ocular melanoma develops spread of the cancer. There are two factors that are probably the most important, and one, which we have known about for several decades, is tumor size. So the larger the tumor is in the eye, the higher the chance that the cancer can spread. And secondly, for the past almost 2 decades, we have known about markers in the tumor tissue itself that can predict a high risk of spread. And there's one finding called monosomy 3. Monosomy 3 means a loss of one whole copy of chromosome 3 in the tumor tissue. And it is the strongest risk factor associated with metastatic spread. There have been more recent tests that can tell us similar findings, and a gene expression test has been able to group melanoma into class 1, which is a good prognosis, so low risk for spread, and a class 2, which means a high risk of spread. And we know that people with class 2 melanomas, it correlates with having monosomy 3 of the chromosomes. Here's just an example of a test that can detect this only one copy of chromosome 3 in tumor tissue. So when we think of ocular melanoma, the tumors can be thought of as almost 2 different types. So you might have a good prognosis melanoma where we have disomy, or 2 copies of 3 in a class 1 where we don't get liver metastasis, or you can have a bad prognosis melanoma where there is monosomy 3 in class 2 and the patient has a high risk of the cancer spreading to the liver. Now, what are treatments for the eye? Well, I'm going to just touch on this briefly, but they sort of fall into 2 main categories. One is taking the eye out, or enucleation. And the second category of treatments involve treatments that can help save the eye. So most commonly, radiation is used when we're trying to conserve the eye. And the commonest treatment for melanoma is using an iodine-125 plaque brachytherapy. And this picture demonstrates a patient during surgery where this plaque, which appears like a gold disc, which has seeds of radiation on the underside, is placed on the wall of the eye directly behind the tumor. There are other treatments, other forms of radiation. Proton beam is another way that melanomas can be treated. And certainly there are other types of treatment where laser or tumor resection may be performed, but these are far less successful in terms of achieving local tumor control, but may be indicated in certain situations. So at our oncology center at UCLA, we have 3 main goals. And our first goal is to save life, our second is to save the eye, and our third is to save the sight. So how can we do this? How can we save a life? Well, by treating the primary melanoma of the eye, we may be able to influence what happens ultimately with the patient. And part of this goes back to being very observant over suspicious lesions that might not represent melanomas or that might have a high risk of transforming to melanoma. So watching very suspicious lesions closely. And for example, here's a patient who is a gentleman in his 60s who was found to have this flat choroidal nevus. And we recommended that he should come back for yearly follow-up. However, he didn't return, and 6 years later, his small flat nevus grew into a very large melanoma. And his vision was very poor, so it was recommended that he have removal of the eye for treatment. And treating small choroidal melanomas early. And this is something that we have advocated very strongly for. And traditionally, ophthalmologists would often observe lesions and observe small tumors because there was a chance they might not grow. But we know, and especially with a lot of our imaging technology, that we can identify and diagnose melanomas very early. Here's an example. This is a photograph showing a small pigmented choroidal lesion near the optic nerve in the fundus of a patient. And this looked very small. The patient had very mild symptoms. However, when we did another test, and this is a test called an OCT scan, where we can actually scan right through the tumor, you can see, and it's highlighted here, here is the melanoma. And it's about 1 millimeter thick. This is very small, but it is active because you can see that there's a cleft of subretinal fluid and it's leaking. So this patient should be treated because if we treat a tumor when it's so small, we don't have to give the patient as much radiation as if we watched and waited for the tumor to grow even larger. So it's also important to inform and engage patients with information about their cancer. And what we do, and what many centers do, is obtain a sample of the tumor to get information about the molecular prognosis of the cancer. So by taking a biopsy of the tumor, we can tell if the patient is at low risk for metastasis or at high risk for metastasis. And we can combine the information that we get with age, gender, and tumor size so that a patient can have a better understanding of their level of risk of the cancer spreading. And the more information people have and know about their diagnosis, the better they are able to follow up and get the appropriate care. Here's an example of some information that has come back from a biopsy. This is an example of one of the types of reports that we can generate now. And this is a 79-year-old female with a very large melanoma that was 10 millimeters in height, but it was negative for the monosomy 3, or the high-risk marker. So we can put together a nomogram that compares our patient to a control population and give them some idea what their mortality may be in 3, 5, 10 years or more. And here are the survivorship curves. So all this information is available, and we find it's very useful to give to our patients. And certainly it's very important to work closely with oncologists who are experts in treating ocular melanoma. Many of our patients are followed with screens, and we want to focus on the liver and the abdomen, and patients can have a variety of imaging tests. And it's always recommended that the patient see a person who is familiar with ocular melanoma so that if they ever find something suspicious, the patient can immediately be informed of potential clinical trials or even early treatments for the liver to help improve survival. So I'm going to tell you some things about our program at UCLA. Fine needle aspiration biopsy, which I've touched on, silicone oil, which we use to help shield the radiation, and some things that we do to help monitor our patients closely so that they can have optimum vision. So fine needle biopsy is a way that we can obtain tumor from the tissue during their plaque or radiation surgery. And this is a technique which, for obtaining molecular prognosis, was developed here at UCLA, and we're the first center in North America to to offer this to patients. And we also established that this is a very safe technique. Not only is it safe for the eye, but it does not alter the metastatic risk of a patient. And you can see here a very small needle being inserted into the tumor that can give us a ton of information. And these are some of the things that we can get. We can get cytopathology, which is confirmation of our diagnosis. We can get the molecular prognostication, so we can identify patients at high risk for metastasis, whether they have the monosomy 3 or if they're class 1 or class 2. We have tissue now from the primary tumor that can be used for research. Before we had biopsy, we had no idea what was in these tumors unless the patient had their eye removed. Now we have a resource of materials that can be used for further study to understand how this cancer works. And what we have found, as well as other centers as we perform research in health psychology, is that patients want information about their cancer, regardless if it will affect their treatment going forward or not. And it comes down to simply, wouldn't you want to know if your cancer was going to have a high risk of spreading, or if you were one of those people who had a low risk of the cancer spreading? And here's just an example of this. Is our first publication of our first group of patients that we put together demonstrating the feasibility of this technique. And since then, our center has put forth a lot of different papers in the literature showing the safety, comparing different methods of biopsy, and we continue to evolve in our methods of obtaining tissue so that now we can biopsy even the smallest melanomas that are diagnosable. So now I'd like to share with you some information about how we can alter the radiation that's used to treat the tumor to help vision. So one of the problems that I touched on with melanoma is in the side effects of the treatment. People can lose their vision from the radiation treatment. In general, the larger the tumor, the greater the radiation, so the greater the risk to the eye. And in many studies that have looked at patients over time who have had this treatment, about half of patients will have vision worse than 2200 in the treated eye at 3 years after their treatment. So that's, once vision is worse than 2200 and they can't read the eye chart, the functionability of the eye is very poor. So currently, there are no treatments that successfully cure optic neuropathy, which is the optic nerve being affected by radiation, or maculopathy, diseases in the macula or center sight. We have different drugs now that we use to inject into the eye that we have taken from other areas of ophthalmology, but none of these are curative or show long-term promise. And this really underscores the fact that the damage from the radiation happens at the time that the radiation is delivered. So if we had a way of shielding the nerve and the macula during the plaque treatment, this might help minimize the damage and the vision loss from patients. So this is how a melanoma undergoes brachytherapy or plaque treatment. The plaque covers the tumor so that the tumor is appropriately treated. And radiation from the plaque, in addition to affecting the tumor, also has some effect on the healthy non-tumor parts of the eye. If we were able to fill the vitreous cavity, where normally there's vitreous humor, and replace it with a substance that might attenuate the radiation, we could perhaps lower the amount of radiation that affects the healthy tissues. So this is exactly what we demonstrated to be possible, and now this is a treatment that we offer patients, particularly those people who have very large tumors. And we found that using silicone oil, which is a substance that we already use to repair retinal attachment, can attenuate the radiation by about 50 to 60%. And this also, in our first clinical series, shows that we can reduce radiation retinopathy by 2 years. And for large melanomas, the vision is significantly better at 1 year than if the patient just had plaque therapy alone. And these are just some the vision comparisons in plaque versus plaque treatment with the silicone oil. And this is our initial publication and our follow-up clinical study where we compared patients who had the regular treatment and those who had silicone oil placement at the same time. And here's just a chart showing in just patients with very large tumors, the blue bars are the plaque alone, the red bars are the plaque with silicone oil. And you can see that there's many more patients, significantly more with better vision outcomes that had the oil, and then those patients with very poor vision outcomes far fewer in those patients who also had plaque with silicone oil. Here's just an example of a patient who significantly benefited from this. This is a gentleman who started off with 20/40 vision, and he had a very large tumor, 9.78 millimeters, and its largest basal dimension, the LBD, was 16 millimeters. And this was, in this particular patient, in the traditional way of treating this patient would have his eye removed from the get-go. However, he underwent the plaque treatment with a silicone oil placement, and here is the patient about 1 month later, and there's silicone oil present in the eye. Oh, I think we have different pictures here. So this patient, after a year and a half and after the tumor was treated, maintained his 20/40 vision and did excellently with good tumor control. So finally, I want to talk about some of the other things that we do for patients that have had treatment for melanoma. Oftentimes, other complications, I mentioned some of the radiation side effects, but people who have melanoma of the eye are susceptible to other diseases that we see in ophthalmology, such as macular degeneration, glaucoma, and retinal detachment. But many people are very hesitant to offer the same level of treatment for a patient who might have a tumor in their eye. And much of this comes from the belief that interfering or meddling with the eye that has had a treated melanoma might help seed the cancer elsewhere in the body. But now that we understand that it's the biology of the cancer, whether the patient has a monosomy 3 profile or a class 2 profile, that influences metastasis and not anything that we do to the eye that influences metastasis, it's very important to treat all these conditions, because otherwise the vision will be lost for very treatable reasons. So for example, patients with melanoma of the eye often get retinal detachment. The tumor leaks fluid under the retina, and even sometimes after treatment, a year or two later, the patient may develop retinal detachment that can cause them to lose their vision. These eyes can be treated surgically just like a patient who didn't have a melanoma in their eye. Patients with melanoma are at a slightly higher risk of developing glaucoma. And I often find that patients are on all the different drops for glaucoma, but the glaucoma surgeon is hesitant to offer glaucoma surgery to properly control the pressure. Finally, a patient with a melanoma in their eye may also develop cataract. And I think cataract is a condition that is felt to be most appropriate to treat in these eyes, but we're also finding that there is a little reluctancy to offer treatment. And certainly if a patient develops trouble with the blood supply or circulation in the eye, laser treatments and giving these new drugs that we have to inject in the eye is very helpful. So in summary, uveal melanoma or ocular melanoma remains very challenging, not just because it can affect the vision, but because it can affect the life of a patient. And it's very important that we continue to pursue ways of detecting this early, treating this early, and submitting material for research so that we can better understand the cancer. And at our center, at the Stein and Doheny Eye Institutes, we really focus on the patient's individual desires. For some patients, they might not want a lot of treatments to their eye, and it might not be the best option to offer a lot of treatments when a patient would rather have the eye removed because it's giving them discomfort. And also, patients want to know information about their tumor and about their risk of metastasis. So we want to focus on doing everything we can to offer the best vision and to save the eye. And in many cases, treating these side effects that can happen, not only does it help the vision, but it results in less eye loss down the road. Biopsy for molecular prognostication is really considered standard at this time, and almost every center offers this so that the patients have more information about their cancer and can better equip themselves with follow-up and seeing the appropriate specialists. And certainly, we do have some strategies for reducing radiation retinopathy, but there continues to be many challenges in this disease that we will continue to strive and overcome eventually. And I want to thank you very much for the opportunity to present information about our center, and I welcome any questions. Thank you. All right, so one of the questions is, can I develop ocular melanoma from another form of melanoma? That's a very good question, because when we use the word melanoma, for many people we interchange skin and eye, and it's all sort of the same package, when in fact ocular melanoma and skin melanoma are biologically very distinct and very different. Some of the risk factors of a person who may have developed skin melanoma are similar to those with a patient who may develop ocular melanoma, those being having lighter pigmentation or more fair complexion. But the idea of developing an eye melanoma because you already have skin melanoma has not been proven, and there is no evidence that you can develop the skin melanoma from the eye. And another question here is, what is uveal coloboma, I think, from what I understand, and what are the existing treatments for it? I think that word is coloboma. But a coloboma is a defect that one acquires during the development. So it happens when a person is born. They're born with this defect, and usually a coloboma in the eye happens very early in the stage of development, and it's diagnosed often when a person is a child. And it results from an improper closure of the eye, usually near the optic nerve. So when a person is examined, the optic nerve looks very unusual, and people can have vision totally unaffected, or the vision can be very poor in the eye, depending on what structures are affected. So this is a little bit different from melanoma, which is a type of cancer, and there are not very many good treatments for a coloboma because it is something that a person acquires from birth. So there may be some things that a child, that if it's diagnosed early, things that can help encourage the use of any vision in the eye, such as some of the standard treatments for amblyopia, which means sort of a lazy eye or an eye that doesn't work as well. But that would really depend on the extent of the disease, and it would be important to discuss this with the person's ophthalmologist to see if there's any benefit in doing any sort of vision therapy. And a final question, what do I need to know about caring for someone with ocular melanoma? I think that's a very important question, and I think about this almost every day because I see patients with this condition. And I think one of the most important things is, well, there's sort of two things I think are important. One is to encourage the person to continue to follow up the health of their eye and the health of their body, because not only are we having more and more advances in ophthalmology, but the oncology world is experiencing a tremendous increase in the number of successful therapies for metastatic cancer, whether it be breast or melanoma. And patients with ocular melanoma can certainly benefit from this. So it's important to keep in touch, have an oncologist who is an expert in the area and can help guide the patient. But also I think this is a very hopeful kind of cancer because it can be identified and diagnosed, and there's a very strong community of people that have come together really through the internet that have been able to share resources and to discuss treatment options. And I've found that probably over the last 5 to 6 years, much of the big things in our field have been driven by patients, and patients wanting information and wanting to be properly screened and with close monitoring. So I think it's very hopeful because the field continues to change and faster than it has ever been in the past. And it's important to stay on top of the eye and the whole body because everything has some role in the development of the cancer spreads. All right, thank you very much.